now. Okay. So moving on to toxicities. So just going back to that timeline, because I think it's really important to have an understanding of what your risks are in that time frame. So if you're meeting a patient in the day therapy area and they're for CAR T, or if they're 3 months post CAR T, or if you're meeting them in ED, I think it's really important to think about where they are in that trajectory, because what you're looking for is very different. So in that dark, almost brown, your key concern from meeting the patient to the time of their infusion is rapidly progressive disease. I've already mentioned that it's an exclusion criteria. And so if you have a patient with cryopreserved cells that may have progressed, then you have a bit more movement to be able to try and control their disease before you infuse them. If you have a fresh product or a shorter manufacturing time, that product doesn't allow for bridging therapy. It allows for steroids. So these patients do need a lot of regular monitoring, regular pathology monitoring as well. Infection, like anyone, heavily pre-treated patient cohorts. So if a patient had an active infection 1 week and even the week of infusion, we would delay the infusion, okay? And then thinking about other chemotherapy-related toxicities. These patients may have had lots of anthracyclines in their lifetime. Do they have cardiac toxicities? There's a whole range to think about, in particularly thinking about patients that are post-autograft or post-allograft as well. As I mentioned, if you get to the infusion, then your toxicities or your concerns are based on chemotherapy CAR T related, okay? And we'll talk about your key effects there. And so from infusion to day 30, we're thinking about that as your highest alert, okay? So it's really important to know what day a patient is up to. We always reference that day plus. When we get out to the 1 month, there are still some side effects. So patients can have pancytopenia. There is potential for ongoing neurotoxicity, and we'll talk about that. But your imminent phase toxicity start to settle, okay? And then long-term follow-up we'll talk about a little bit later, but this is a pretty new therapy, and so it's an area that we're not as aware of. Okay, so trying to think about that, those arrows, and think about what are your key toxicities in the early phase, so day 0 to day 30 of CAR T therapy, and what are some delayed potential toxicities. If you haven't seen or read this article, and you're working in areas that might have products or immune effector products that have risks of cytokine release syndrome or neurotoxicity, I highly recommend you read it. You can Google ASTCT consensus grading. Yes, great. And so just to flag, this is a range of hematologists that got together, and there's multiple grading scales that currently exist for cytokine release syndrome and neurotoxicity. And it's pretty confusing that with one grading scale, a patient might grade 2 or then 1 on another, and some of the other ones, they're quite hard to follow. This harmonizes CRS and ICANS, and so I'll refer to that. And when I'm talking about our toxicity management, toxicity is based on a grading, so that's why it's important. But I'll refer to our guidelines based on this article and their recommendations, okay? In the next 6 months, these range of haematologists are currently developing toxicity management guidelines and algorithms, and that should be available. So keep an eye out for that, or I'll be sending it out to all key clinical areas as well. So early phase, what are we looking at? We're looking at cytokine release syndrome. Now, just to make it a little bit complicated, the ASTCT consensus grading has redefined neurotoxicity as something known as immune effector cell-associated neurotoxicity syndrome. So you might hear an acronym going around or people talking about ICANS. If you ICANS, that's your acronym for neurotoxicity.
You make it longer, guys.
Okay. I won't spend a lot of time talking about febrile neutropenia because I'm sure most of you know about it, but if you think about the medications that were given prior to infusion, the lymphodepletion, they can cause neutropenia, okay? Most patients will be coming to that nadir at the time of their infusion or in the first week following. And so patients are at high risk of febrile neutropenia. So you always need to think about that as a differential, okay? Tumor lysis syndrome, not as common in the lymphoma population, but in ALL, yes. And so if patients are being infused, they need to be monitored pretty closely for tumor lysis. And that goes for their lymphodepletion as well. From a delayed perspective, patients can get hypoglobulinic. So if you think about your disease, so ALL is driven from a B cell malignancy, okay? Your CAR T cells have destroyed those B cells, your malignant cells, but also your healthy B cells. And as a result, these patients can require immune replacement, so IVIG in the long term, which when you think about it, your persistent or ongoing depletion of your B cells is hopeful that your CAR T cells are persisting. Okay, so when you mentioned it before about how do we tell about CAR T persistence, this is a surrogate way of monitoring that persistence. Does that make sense? And pancytopenia. So despite CD19 not being a target on the bone marrow, these patients for some reason can have significant cytopenias up to 12 months after their infusions. So requiring platelet support, requiring GCSF support, or less commonly blood transfusions. So although they're after that high risk period, they can still go on to have pretty profound cytopenias. And it's not well understood why, but it can be quite concerning for some patients. Okay, I made note of this before. See, on the left-hand side, don't worry about all of the letters in there. So you've got a Penn grading scale, you've got a CTCAE scale, and you've got a Lee 2014, and there's slight variance in how they define what grade 1 CRS is or grade 2, etc. You don't need to know the ins and outs of it. This is just to acknowledge that there's lots of different grading scales. And like I mentioned before, the key emphasis is on having a broad knowledge about these toxicities so you can identify and manage them. All right, so take the emphasis off on which grading scale are you following and just apply the concepts really broadly is my advice. Because this consensus grading scale, the article that you've got was developed published last November, December, a lot of the clinical trials don't use that grading scale because they've already been written and prepared. As we move on, we'll see it more commonly. But in the commercial setting, we're applying that consensus grading scale. So we're going to talk about those individual toxicities, but I'll refer to a case study. So I have this patient's permission, and I just wanted to give you an overview of her prior treatment and prior therapy, and think about not just physically and psychosocially what this patient has been through, but then apply it to cytokine release syndrome and neurotoxicity. So this patient was diagnosed at the age of 10 with ALL, acute lymphoblastic leukemia. And you can see here, you don't need to read it all, but count the numbers. Lucy had 6 relapses, and her 6th relapse was even following an allogeneic stem cell transplant. And so the 6th relapse was both in her bone marrow, but also in her CNS. Okay. So we met her in June when she was referred over on the day that she was relapsed, and we had collected her lymphocytes as soon as possible because she obviously needed treatment. She presented with a HB in the 50s, was asymptomatic of her CNS disease, but very pancytopenic. At that stage, in thinking about Melbourne is the only site for ALL or to provide the product at the moment. So this patient was from interstate. They travelled with their mum and relocated for that period of time. So that's a huge undertaking. And they said to me, "Oh, it's okay. We had our allograft in Sydney, so we're just sort of moving around." But yeah, there's lots of things to consider. We get so focused on the physical and needing to treat these patients so quickly, but there's also lots of other considerations that you need to be mindful of. So we collected the lymphocytes immediately, and because there were so many previous CNS relapses, we needed to be confident that we could clear the CNS to be able to treat with the CAR-T therapy. Active CNS disease is an exclusion for patients, essentially. It's high risk of neurotoxicity. And there are clinical trials looking at patients in the US that may have active CNS disease and whether it's safe, but we don't know the outcome of those trials just yet. Okay, cells collected, started on bridging, pretty intensive chemotherapy, and we saw pretty quickly that we could clear the CNS, and then the cells were sent to be manufactured. Because this is one of our first ALL patients, they remained in Victoria for that bridging therapy. Okay, that's a big financial burden, and we'll talk about that later. So in mid-July, we infused the product. So the 15th of July was day 0, the day of the infusion. Okay, and we'll go back and reference Lucy when we get to the toxicities. So the ASCTC consensus grading scale defines CRS as a physiological response. And what I want you to know, it's not just unique to CAR-T cell therapy. So we're applying this broadly to immune effector cell products, so your bispecific antibodies. So it's not just for CAR-T, okay? And it's the activation of the immune system post the infusion of these cells that causes CRS. Now, to be called CRS, it has to include a fever. You don't have CRS if you're hypotensive and afebrile. Okay, you think about some other causes. The patient must have a fever, and then the way that the consensus grading is sort of, this is your level of intervention, so your hypotension, or how hypotensive a patient is, how hypoxic they are, and then end organ function as well. Okay, so thinking about fever, hypotension and hypoxia. Okay, they're your key things at the bedside that you're thinking about. So why does it happen? What's the cause? So as the cells are infused, it's that peak expansion of these T cells, okay? And we want that peak expansion, but it just leads to toxicity, okay? And as a result, you get really high levels in your bloodstream of your serum cytokine levels, all right? We don't actually draw blood and assess them, but in the clinical trials, they looked at that expansion and those levels, okay? Think about cells go in, that expansion, that expansion leads to your toxicities. We've already thought about those clinical presentations, so fever, hypotension and hypoxia, but also thinking about your septic or SIRS patient, okay, your other elements of elevated respiratory rate, tachycardia as well. All right. So CRS happens early on, okay, in the first week generally, anywhere from day 2 to day 7. It's pretty uncommon to get delayed CRS in many weeks post. So thinking about if you're looking after a patient in that first week, your key thoughts are cytokine release syndrome, all right? So how do you treat a patient that is neutropenic because they've had lymphodepletion, they've got a fever and they've got a borderline blood pressure of 90? So you need to think about what other potential causes. We can't just presume that this is cytokine release syndrome. We'd hope it is, but febrile neutropenia, other causes of infection as well, okay? So you initiate the septic pathway and continue a septic pathway. We do manage some patients as outpatients, so they're mandatory admissions straight into the hospital, okay? At the moment, because we're still developing our experience, if patients are outpatients, they need to be directly admitted to Peter Mac or come via our ED, the Royal Melbourne ED. Only because the knowledge of cytokine release syndrome and CAR T cell therapy at external sites isn't quite there. This is a really expensive therapy. It's the potential of a cure. So we don't want to do something that might affect the outcome of the CAR T. So you start a septic pathway, giving IV fluids. We don't go too aggressive with the IV therapy because that potential for capillary leak syndrome or hypoxia. So we engage our intensive care team pretty early on, and so they have a really key involvement in the care of these patients. So if a patient does develop CRS, we notify our team straight away just to say, FYI, it might only be a fever, but just to put them on high alert. Okay, to support the blood pressure, we usually would intervene with inotropic support much earlier than in a septic patient. All right.
So that will be ICU admission.
Good question, Angel.
Yeah, because we can get that one. Sorry, I'm from short stay. Inotrope support is only across.
Yeah.
Or if a surgery patient, it will just be ERD.
Yeah. So I suppose that depends on your clinical capacity as well. So if it's an inotrope, then yes, it does need to go to ICU. But if a patient has persistent hypotension, have maximized or have had a number of litres of fluid, so 2 to 3 litres, but they may, ideally they should go to ICU, okay?
Are they flagged as soon as these things happen?
Yeah, there's an alert email. So one of the key things for all CAR T patients, on the day of infusion, there's a big alert email that goes out. So there's lots of teams involved with these patients. It's not just hematology, it's your bed access, it's your pharmacy, it's your high acuity or ICU teams, it's the emergency, it's neuro. There are so many teams involved. So there's an alert email on the day of infusion. And then if there was a toxicity, then we alert again that particular team.
Oh, so obviously that's a MET call. That patient would make MET call. So in the EMR, just thinking ahead with the EMR, will that be that'll be a flag that comes up, will it? So, because just some of the meetings that we've been to, you know, you have to put in a patient problem that puts up an alert. So will that be a discrete alert then that will come up to say patient having CAR T cell therapy?
That's a good question. I don't have the answer. We're only just in January, we're building in our toxicity. But if there's a meeting,
I go to the alerts and allergies EMR group. I can raise that at that group because they're talking about all those different alerts that are going to come up and how people would know that. And so some of the problems the nurses will actually be allowed to add a problem in as free text. So whether that, you know, whether they add CAR T cell therapy or whether that's actually already built into the system.
Yeah. Okay, that's a good point. I've written that down. But if there's any meetings or anything, so there is, if you go back and have a look at your serum cytokines in your right-hand storm, so I always think about CRS as a storm, okay? So your IL-6, we can switch that off, and there's a drug called tocilizumab or Toci. It's a IL-6 receptor antagonist. And so it binds to that IL-6 and interferes with that signalling pathway. And that can settle down the cytokine release syndrome. It's soluble, so usually patients, it won't revert with one single dose and it will take some time. And there is evidence that's starting to develop that multiple doses of tocilizumab can lead to an increased risk of neurotoxicity. Hasn't been published, but this is anecdotal experience from our colleagues in the US. So that's one thing that we're starting to learn more about. So tocilizumab is a monoclonal antibody. So in our setting, it's kept in the kept by our pharmacy, and so it gets delivered to the ward in an after-hours capacity. You need to do lots of planning from a service perspective. So there are separate supplies for our clinical trials and our commercial trial, and usually if you need it after hours, it's an on-call pharmacist that needs to come in, make it up and deliver it to your area. Or your nurses are currently drawing it up on the ward here at Peter Mac. So here we have done a lot of work from a bedside perspective of how can you identify or how can you be assisted to manage CAR T patients, or how can you differentiate between a febrile neutropenic patient. And so these quick guides are designed to be at the top of the bed, on your ID badge, or printed out in a patient folder. And so they're for all staff that are caring for these patients. So up the top you can see we're looking at your fever, hypertension and O2, sorry. And then as you move down with your grade, traffic light system always, your level of intervention or level of requirements is increasing. So if you look at grade 2 as an example, your febrile patient, we've already initiated a septic pathway, blood cultures are gone. You've got a systolic blood pressure of 90. What are you going to do? Yeah, So giving fluids for hypotension, your high acuity or your ICU team are aware of the patient. They might not know about CAR T therapy, so you're educating them, okay? Also thinking about early intervention with tocilizumab as well. So initially when we were starting this whole process, we thought that tocilizumab would only be given in the intensive care setting, but early intervention we're learning is key to these patients, okay? So we've popped on the guide on how it's delivered, and so there is a few key things that we avoid with CAR T patients. So in your top, you can see not for GCSF. There's no evidence to support why we don't give GCSF, but there's a theoretical thought that giving G would exacerbate that cytokine release. Hasn't been proven. I'm sure in the coming weeks to months, we might even be reconsidering this, because we've heard from our US colleagues that they're giving GCSF safely in that first 30 days, okay? So this is new. There's lots of things that may be changing as well. With cytokine release syndrome, we want to avoid steroids at all times unless it's quite a significant grade or a life-threatening emergency. In your period of cytokine release syndrome, it's early on in the infusion, your peak expansion, if you give steroids, they are likely going to affect the CAR T, all right? So we avoid steroids in cytokine release syndrome in earlier grades, okay? So going back to Lucy, so this is, sorry, I forgot to pop in my respiratory rate in the right-hand side, my graph. So purple line, febrile, 38 degrees, spending quite a significant time febrile, and as you can see from day two, had a fever and remained febrile up to day 8. Pretty high fevers as well, which is not uncommon with patients with CRS, 39 degrees, 40 degrees persistent. What I haven't shown in my other right-hand column is she also had quite a few MET calls for tachypnea up to 32 from memory or higher. And so although she did not have hypotension or hypoxia with a persistent respiratory rate above 24 to 32 in that 2 to 5 days, the decision was that she would get a dose of tocilizumab because it was only a matter of time till she decompensated. Okay. She had 1 dose, didn't really have any improvement, and then had a second dose 12 hours later. And so the way we give tocilizumab is you give a single dose and then the patient is reviewed 8 hours later. You don't write up a regular dose because we're just learning about the other potential effects. Okay, and the fevers slowly resolved and the cytokine release syndrome settled. All right. So pretty unwell, consistently febrile for quite a few days. No one likes to be having half-hourly observations.
Do we have a guideline for this one? Because I did remember giving that one to one of your patients. She's from New Zealand.
Yeah.
Tocilizumab, because we're flagging her for an ICU bed. But they said she's responding to food. She is already grade 2.
Yeah.
So hypertensive, 89 over 52.
Yeah.
38.5. So we done all this septic work out for her.
Yeah.
That is involved already. And I agree with you. She is one-on-one on my watch in short stay. So after this one, the tocilizumab, because we're looking for a guideline for this. Do we have it in our eye policy, just in case?
There's a guide in eye policy. There's a guide on the toxicity, and it's also in the safety injectables. Tocilizumab is also used for rheumatoid from memory and can be given subcut. So just to flag, it's always an IV infusion. It is mentioned, and I need to rename our toxicity management policy because you have to search chimeric and instead of CAR T.
This
So
one came to me in a vial, then I mix it.
yeah, then you draw it up and then administer. So we do have it on the guides that's directly adapted from the safe injecting guides, but I'll add that to my list.
Please.
And Nick, is there any risk of a reaction to the tocilizumab like there would be with other monoclonal antibodies?
So no, not a monoclonal antibody, but in that, in that policy, what do we call it? The instructions for, what's the safe drawing up of those?
Oh, the hazardous.
Safe handling.
No, thank you. I can never.
But it doesn't.
That won't be around preparation.
It doesn't include preparation.
No, but it highlights it within that policy, sorry. But there isn't any infusion related concerns, no. So ICANS, I'm not going to extend that, or neurotoxicity. So again, it's a pathological process that involves the central nervous system. We know that CAR T cells can cross the blood-brain barrier. We've seen it when we've done our day 30 restaging on our lumbar punctures. And again, it's that engagement of these infused cellular therapies or T cells or immune effector cells. So we're not just thinking about CAR T. It's less clear than CRS, which has to include a fever, may include hypotension and hypoxia. It's a pretty broad spectrum, okay? It may include aphasia, tremors, dysgraphia, so changes in your handwriting. And essentially on your spectrum, the most severe is cerebral edema and seizure, okay? So it's quite variable. So the exact mechanism or the cause of ICANS isn't well understood. And we've talked about that clinical presentation being quite variable. ICANS can occur in isolation. It can occur alongside cytokine release syndrome, so independently or together. Generally, we think that ICANS happens a little later, so from day 7 onwards is our key area, but has occurred earlier, has even occurred up to 8 weeks post-infusion. Patients, for that reason, aren't allowed to drive for 8 weeks after the infusion, and so lots of education needs to go into that communication. And also, for carer education, there is an ongoing or potential risk that there may be a delayed neurotoxicity syndrome. So if a patient falls, then that needs to be escalated. If their tremor is increasing, that they can't pick up their water, then they need to come back into hospital. On your right-hand side is a article that is using an article that talks about our toxicities in the early phase Zuma-1 trial. So that's an earlier product. And their assessment of neurotoxicity initially was through a mini mental examination. And so you can see in day 5, there's quite a significant change in the handwriting. And that's why the ASCTC consensus grading has included a handwriting assessment, and essentially for their assessment, they've harmonised a mini mental in some key elements for a grading assessment. Okay, I just always pop that in because I think it's a really good example of, although there's only a 2-point difference, but dysgraphia is often the first sign of neurotoxicity in these patients. So how do we manage these patients? That's a quick guide, which we'll talk through with this. There is part of that mini mental examination. So there has been an amendment essentially, and a patient gets an ICE grading, immune cell encephalopathy score. All right, I think on your handouts, there's multiple pages on there, so I'm happy to print this out and flick it on to anyone. So a patient needs to be assessed for a 10-point grading, a 10-point grading, okay? You're assessing their ability to orientate, 4 points. You're assessing their ability to name objects, their ability to follow simple commands, to write a standard sentence, and their attention span, okay? So you can follow these guides exactly. 10 out of 10, you've got no concern for ICANS, although there may be scenarios where, although a patient is scoring a 10 out of 10, there is something that is not quite right, okay? We do these assessments on the ward 3 times a day on a minimum, so at the start of each shift, each nurse, medical are doing them as well. And at the moment, if we have outpatients, I get their carer to do them with them as well. So the ICE score, or that 10-point score, is just one element that we think about when we're assessing for ICANS. You're also looking at the level of consciousness, if there's any seizure activity, if there's any changes in their motor findings, and then looking for cerebral edema, okay? So we're using that ICE score predominantly on the ward to identify for ICANS, but in the total score, there's other elements, or the total tool, that we're also assessing for. Okay. And I'll just go back to our ICANS management sheet. So you're looking for a decrease in that ICE score, as we said. And so 10 out of 10 is great, 7 out of 10, not so good. And what is your management then? So you're escalating their care immediately, and we generally do that directly to the registrar, or we have a CAR-T consultant on call. In hours, after hours, regardless, they get escalated. Your immediate concern is for deterioration in any neurological aspects, so you're increasing your frequency of the assessment. At the moment, we've put in our guidelines for a 30-minute, it may be more, but we encourage that conversation. How frequently should we be doing this assessment? You're assessing, or you're mindful of their swallow and the risk of aspiration, and if you're in hours and a patient's deteriorating, then you would assess their oral meds and switch them to IV, or if the patient's an outpatient, you directly admit them to the ward. And then you're looking for if there's any structural changes or any edema developing, and so an MRI brain is urgently arranged, or an EEG. So we mentioned that these can happen in isolation, but if there is CRS that may be driving this, the patient might be treated with tocilizumab. And generally, because of the concern of that spectrum of neurotoxicity or developing to quite a significant outcome, we do use corticosteroids much earlier in the picture. And if you think about when neurotoxicity occurs, your peak expansion has hopefully already happened. All right, so risk is a little bit less. So it's quite confusing if you're at the bedside saying, don't give steroids, don't give steroids. Just thinking about what are you treating, what's the risk behind. But my advice is, if you're ever giving steroids in CAR-T, question it and just double check with the most senior person. Any questions about neurotoxicity for these tools? Again, they're a guide. So going back to Lucy again and thinking about when she was febrile, so from day 2 febrile, and then also still febrile at day 6. She had half-hourly obs, she hadn't slept, she was young, she was grumpy, she was annoyed. And we're constantly asking her these questions and to write a sentence. And then on day 6, that evening, leave me alone, no, and refused. And since then, we've built that into our guidelines that if a refusal of a toxicity assessment is a positive assessment, okay? And the reason that is because the patient had 12 hours later, when we assessed them on the ward round, had actually had grade 3 neurotoxicity. And so just quickly go here, you can see in the bottom column, sorry, it's a really bad scanning on my behalf, you can see the change in the handwriting, but it was more so actually watching those motor skills for Lucy to do the assessment. So her trying to pick up a pen, she had a tremor, and her motor skills were pretty appalling for a young, otherwise well. So it's not just looking at these tools, it's looking at how you get to that score, how you get to that response, and combining that all together. Okay, so it had gone from a 10 out of 10 score to 2 pretty soon. So on day 7, she got a dose of dexamethasone, 10 milligrams IV, and she improved pretty significantly, but 8 hours later she was assessed and she had a BD dose of 10 of dexamethasone. Okay, and her symptoms resolved. She's had no long-term deficit, and what I can tell you is the patient's in an MRD, negative CR at 1 month, 3 months, and we'll have 6 months restaging early next year. In this case, there hasn't been an effect on the efficacy of her therapy. Okay. So looking in your right-hand column, how frequently these toxicities occur. So in your right-hand column is tisagen lec-lucil, and that's the Novartis product. So we mentioned those pivotal clinical trials. So in diffuse large B-cell lymphoma, it was the Juliet clinical trial. And in that clinical trial, they used a different grading scale, but 58% of their patients had any grade of CRS, and 22 needed high intervention, so grade 3. Okay. Having a look at the children, so ALL, 77% of patients had CRS, and about 47, so it's a pretty high amount of patients that had grade 3 CRS. And so thinking about why patients might be or might have a higher grade of toxicity would be disease burden. So high blast count in the bone marrow, peripheral blast count, extramedullary disease generally leads to a higher grade of cytokine release syndrome, and we've definitely seen that in our experience. And then thinking about neurotoxicity, so in the Novartis product again, 21% of patients had any grade with lymphoma, any grade neurotoxicity, but 12% of those had a higher grade requiring higher intervention. In the Aliana trial, there was 40%, so high number of patients, but only 13% requiring high level care. So if you have a look in the left-hand column, Zuma is the Axicell product. That's a product I mentioned with the shorter manufacturing time. And so the higher grade of CRS is quite small at 13%, But looking at your neurotoxicity percentage between the left and the far right-hand column, you can see that any grade of neurotoxicity is quite higher at 64%, but their grade 3 neurotoxicity is almost double of that. Okay, so these products do have a higher propensity to for neurotoxicity or ICANS, the Axicell products. All right, so just thinking about, and I know it's really difficult because there are so many products that you might come across in clinical trials or in commercial access, but always ask, what are the key risks for these products? What's the higher percentage? What's the patient's disease burden? Do they have or have they had CNS disease, or just thinking about those things that might lead to a high potential of toxicity. Okay. Can we go back over anything with toxicities?
Just curious about thinking about handwriting and that being such a major assessment.
Yeah.
If we have a 2-year-old having T-cell.
Yeah, great question.
Are there guides out there for populations?
It's in that article actually, the ASCTC, they actually have adapted a pediatric version. And I don't know all the domains off the top of my head, I'm really sorry, but it is, they have assessed for peds as well. Yeah. And I know that there's some of our colleagues from the children's online, but sorry, I should have prepped that for you as well. Any other questions?
Is there a point at which the disease burden would be considered too high to go ahead with the infusion?
Yes, so we don't have any definitive scheduling for when to, so clinical trials are obviously pretty structured, but even their restaging or in lymphoma, their PETs prior to infusion can be, 4 to 6 weeks out. So it is based on clinical assessment, and so thinking about those other markers. So we had a patient that was starting lymphodepletion chemotherapy, and he was day 2 and called me and said, yeah, I've got some terrible abdo pain. Do you think I could be constipated, or is that an effect from the chemotherapy depletion, lymphodepletion? But his bulk of disease was abdominal, and he was actually progressing. So, it's important to think about where's the bulk of disease, what are the symptoms, and always being hyper alert for these patients. And so they do need a really close contact from a nursing and medical perspective in that lead up phase as well. So we don't necessarily just restage prior to their infusion. It's not a mandated, a lot of it is a clinical assessment.
And did he go ahead with it?
He actually had his lymphodepletion, had high dose, he had methylpred, and then so the time frame between his methylpred was confirmed, so the last dose, the washout period was 72 hours, and then he was infused. So there are lots of washout periods for multiple drugs, intrathecal chemo for the ALL population, and so they are in manuals. So each drug company has their disease manual that goes from point of collection through to infusion as well. So if you haven't seen them, I can forward them on. They're actually really interesting to read. Any other questions about Cal?
Just what percentage of patients who are referred actually get to the infusion stage? Are we talking most patients, or?
I can't give you an exact number, but we had one patient that had collected and progressed, but his cells are being sent to be manufactured, and he was our first complete manufacturing failure. So they couldn't create a product, and in that time he'd progressed and had several lines of therapy and a decrease in his performance status. So he was receiving treatment and then planned for recollection, but had actually progressed in that time.
Sorry, just with that example, when there's a manufacturing failure, has there ever been a consideration for like a T-cell donor therapy?
Yeah, so one of the clinical trials, so essentially if a patient can be recollected, they are. The other thing that is used to try and improve the efficacy, and there's a little bit of literature that's developing, it's not published, is the use of ibrutinib to improve that lymphocyte health. So there is a little bit of knowledge increasing of benefit. I don't think it's well published just yet. And then looking at clinical trials, there are donor-derived products as well. But if you had, those are in early phase clinical trials, so if you had the option to recollect and use something that was well, response rates were well recognised, that'd probably be the preference. The other thing about collection is we thought about, so I'm not too sure if you know about rainy day collections, collect the lymphocytes, freeze them just in case. And we thought about doing that because often the next line of therapy for these patients might affect their lymphocytes, but there are so many other potential pressures that might occur. And so the number of referrals that we were getting into just in case collections wasn't feasible. We didn't have the capacity to actually store and keep all these cells. So as a, unless someone has a clear pathway, we try not to just in case collect these cells.
In terms of at the outpatient, inpatient criteria, is that just based on lymphodepletion, how unwell they are, whether they meet the criteria to be inpatient or outpatient?
Yeah, good question. So firstly, thinking about your product. So the Axicell product is a definite admission to the ward for that 7 days. Clinical trials will often mandate an admission for a number of days. And then thinking about what's their disease burden. If it's really high, theoretically, your risk of toxicity is going to be high. And so recently we had an ALL patient with 60% blasts on his bone marrow prior to lymphodepletion. So that's a high level of disease. So he was admitted to the ward for monitoring. So disease level, and then thinking about other psychosocial. Do they live close to the hospital? Do they have a carer to support them? We generally wouldn't put someone on a program if they, or on the therapy if they didn't have that capacity. If you think about your risk of neurotoxicity or any symptom that could happen at any time and you need to get directly to Peter Mac or nearby, you need someone there that notices that really minute change in your personality or in your motor function to be able to escalate that. So I probably didn't focus on other toxicities as much, but thinking about, as we mentioned, so hypergammaglobulinemia, well, that's pretty clear, but also thinking about those cytopenias. Because we are a referral, the key referral centre between the Children's and Peter Mac, educating referees about there is a potential for long-term cytopenias and this is how it's managed. Good education to the patients that low blood counts might not mean necessarily that treatment is failing, but that they need to be hypervigilant with temperatures and having those blood tests once a week or twice a week and letting you know when they've happened so you can review those results. And patients can be safely managed at home or an outpatient or at their local referring institution. They don't need to come back here to have those bloods monitored on that 30-day basis. Any questions about that? What about toxicities? Is there anything that isn't so clear? Confident on looking at your paradigm and when you might meet a CAR T patient of what you should be looking for? So if you're meeting a patient in week 3, then obviously your key isn't tumor lysis, you're thinking about neurotoxicity. Just try and think about that spectrum of where you are. Okay.